etiology of the condition to the important role lifestyle and behavior play in managing it for improved outcomes. We'll also be discussing how to enhance practice growth using remote hypertension monitoring. Also, throughout the webinar, we encourage you to please submit your questions as they come up. We'll be spending some time on Q&A towards the end of the presentation, and you'll see at the bottom of your screen there's a Q&A button where you can submit your questions at any point. And with that, I'm so excited to introduce you to HealthSnap's co-founder and CEO, Samson Magid, and Director of Product Science, Craig Flanagan. Craig?
Yeah, thank you very much, Sunny. If I click into our first slide here. And there we go. All right, I always like to start from an area of context, and perhaps many of you know this story, but the study of blood pressure as a risk factor really took off after the very public and sudden death of President Franklin Delano Roosevelt 3 months into his new term, his fourth term, in 1945. What's interesting is his doctor at the time saw no problem at all with his 185/105 blood pressure, and is even quoted as saying it was no more than normal for a man of his age. Well, that death jump-started a whole era of research led by the Framingham Heart Study, which informed us of the causal role blood pressure plays in heart disease. And then the Global Burden of Disease study took the seriousness of blood pressure even further by naming it the #1 risk factor for loss of disability-adjusted life years globally, #1 of 67 risk factors studied. And more recently, the SPRINT trial found that if you set an aggressive treatment target of below 120 systolic compared to the traditional 140, that you save more lives. And the threshold soon after was changed for hypertension to be at 130 systolic. And that shift in classification now places 46% of adults in the US in a hypertensive state. Whoa, go back one there. And when you get into causes of individual disease states, here's stroke, you begin to see a pattern that these diseases that afflict us the most are largely due to our lifestyles. And while we can tease out the impact from high blood pressure and assign it as most influential, as you see here, the risk factors that follow manifest themselves into disease in part through increasing blood pressure. And that includes leading dietary issues like being too low in fruit and vegetables, too high in sodium, smoking and activity, and increases in plasma glucose and body weight. So let's take a look at the reasons why some of these negative stimuli that are risk factors in their own right affect blood pressure, and why it makes sense to monitor all of these determinants, not just the blood pressure itself. And let's not go on. There we go. Here's a simplified diagram of the components of blood pressure. It's the product of what's going on both at the heart and at the site of the arteries. And our heart is pumping out around 5 to 6 liters of blood per minute. And that's a product of how many beats that we have per minute, your heart rate, and the volume of blood per beat, known as stroke volume. And stroke volume is dependent upon how much the heart's able to fill up, our preload, and how forceful the heart contracts. And on the other side of the equation, we have peripheral resistance. In other words, how much are our arteries resisting blood flow, because that determines how much effort our heart has to put in. And this peripheral resistance is based on the vascular structure, how rigid or pliable our arteries are, and our vascular function, how responsive they are to cues to dilate and constrict. Much of the research here centers around the production of the potent vasodilator nitric oxide, and while it's not the only molecule that induces the relaxation and dilation of these arteries, it is most influential. And we could further differentiate differences between macrovasculature of larger vessels, the microvasculature of tiny vessels, but we'll hold here for the purposes of our webinar. And we commonly view this targeted approach when it comes to the leading antihypertensive drugs, but we should always look at the same mechanisms of actions approach when it comes to our lifestyle factors. And there we go. And that said, let's take a look at what happens with these variables to induce high blood pressure. We have our daily mental stressors and physical stressors like smoking and poor sleep, and they induce this disruption in autonomic balance that creates a greater sympathetic activity to the heart and blood vessels. And by placing a foot on the heart's accelerator and constriction of the blood vessels downstream, these stressors can be a major culprit, and it makes them a site of targeted intervention. Anything from yoga that focuses on breathing techniques to mindfulness practice, improving your sleep hygiene, and of course, aerobic exercise. And then poor glucose control can affect blood pressure, as insulin appears to increase fluid volume and thicken the arterial walls. Sodium and smoking are known to reduce the bioavailability of nitric oxide. Smoking even destroys the enzymes that create it. In fact, if you smoke long enough, you can permanently destroy those enzymes. And the mechanism behind why sodium causes high blood pressure has been hotly debated. It may provoke water retention due to increased blood pressure in the renal arteries, but perhaps more importantly, sodium can inflame the walls of our arteries and change the structure of the arterial walls to become stiffer, remodeling them to have more collagen and less elastin. And high salt diets are also shown to modulate the activity of that autonomic nervous system. High salt sensitivity appears to be associated with impairments in our baroreflex sensitivity, and without the ability to dial down sympathetic input, we maintain higher blood pressure. And then what about weight gain? Well, some of the same hormonal reasons that cause us to put on the pounds can also cause us to have high blood pressure. We talked about insulin already, but ghrelin, our hunger hormone, is known to lower blood pressure and improve blood pressure control. Poor sleep results in poor ghrelin production, so that can be an added contributor. Then leptin, produced by fat cells in proportion to fat cell size, that's thought to contribute to increased sodium and fluid retention as well. Moving to inactivity, it's tough for patients to view inactivity as abnormal, but the truth is the cells lining our arteries require a shear stress to function properly, and we get that with increased blood flow from physical activity. Without that shear stress, our arteries become more rigid, and we reduce our capacity to produce nitric oxide, and our heart has to work harder. And exercise to the rescue. While your blood pressure will go up during the exercise bout itself, of course, you end up lowering your blood pressure for the rest of those non-exercising hours each day. And so each workout, even if it's a 10-minute walk, can induce a hypotensive effect for hours thereafter, acting sort of like a low-dose drug. And for this reason, tracking the frequency of bouts may be just as important as the overall volume of exercise that a patient is doing. Chronic exercise, on the other hand, will lead to greater ventricular chamber size, which increases stroke volume. And if you have more blood being expelled per beat, then you don't need to beat the heart as often. So we have a reduction in heart rate with greater parasympathetic control. And this is why lowering resting heart rate is an indicator of a very efficient, trained heart. But by inducing that shear stress, we also are producing antioxidants inside the walls of our arteries, and that helps us combat atherosclerosis and heart disease. And one thing that doesn't get enough press is potassium, which only 2% of us get enough of in our diets, but it tends to have opposing effects as sodium does on endothelial function and increases the bioavailability of nitric oxide. And this leads to recommendations such as matching or exceeding our sodium intake with potassium intake. And speaking of nitric oxide, we can also provide substrates and precursors for nitric oxide by eating our nitrates in beets and arugula, or citrulline in watermelon, which some recent research suggests can combat the endothelial dysfunction and the microvasculature caused by diabetes. And for all of these reasons, it's important to not solely keep tabs on your blood pressure, but also monitor these determinants or modifiers of blood pressure. And we designed HealthSnap to do just that. With just a few inputs on behalf of the patient, we're able to compute a series of outputs that are designed to be actionable, such as estimated fitness capacity, physical activity level, cardiovascular disease risk, and 10 dietary indices such as antioxidant index, Mediterranean diet index, gut health, healthy fat, brain health, all based on the patient's dietary questionnaire. And as commercial sensors have improved, we'll always be adding in additional variables such as sleep variables, heart rate variability, which will help monitor autonomic balance so long as the collection is consistent. Our platform is meant to take as much lifestyle data into consideration as possible. So you, as clinicians, can pick and choose what you need to make the most informed decisions. And we view best practice as designing a collection schedule that acts as a morning routine for the patient. Perhaps blood pressure is taken regularly, but body weight maybe on Wednesdays, activity recall every other Friday, dietary questionnaire taken every second or third week. But having a set strategy for remote monitoring beyond blood pressure itself is very helpful. Whoa. And another slide here. Here's a view of patient outcomes within the provider portal. When there are changes in your patient status, we have it so that you can be alerted, and you can always customize the thresholds at which you'd like to be alerted for this data. And on the patient side, we take our role of patient education very seriously, and we use our native app as the delivery messenger of this content. So patients view and track status, and they can sift through content that's designed to be very actionable and facilitate behavioral change for them. That's a brief overview of our system, and I'll kick it away to Samson, who can take over our slide controls.
Awesome. Thank you so much, Craig. I'm going to go out for a run now and eat some beets. You got me motivated here, so thank you. We believe here at HealthSnap that chronic conditions happen between visits, and so should patient care. In light of the global health pandemic of COVID-19, everyone's heard about telemedicine and telehealth, but how do you actually categorize remote patient monitoring under the lens of telemedicine? We view it as two distinct buckets. There's one that's virtual telehealth services, which is what you typically think of as telehealth. And then now there's non-face-to-face services, which includes e-visits and interprofessional consultations. And for today's discussion, I'll be going into a detailed overview of remote patient monitoring and how it's differentiated between the telehealth codes that have historically been thought of as telemedicine. To start off, what are the remote patient monitoring reimbursement codes, and how do I actually incorporate remote hypertension monitoring into my practice? So let's start off just with a brief overview of what the four codes are. The first one is 99453, and that's patient setup and education. You'll see here I show the Medicare national average. These are Medicare codes and reimbursed accordingly as E&M codes as well. So these are billed at the practice level, just like any other office visit, just done remotely now. So that first code is patient setup and education, and that's billed one time. That includes talking about why a patient was prescribed, educating them on the benefits of being monitored by the ordering provider, and then how to use any connected health device as a part of the program. The second code is 99454. And that one is 16 days of data transmission in a rolling 30 days. So in a 30-day time period, a patient would have to transmit either their blood pressure or their resting heart rate data at least 16 times in order to qualify for reimbursement for that code. And then the other two are the professional services code. It's 99457 and 58. And those are both time elements where the first 20 minutes of data review or communication with the patient, and then each additional 20 minutes is 99458. So if you spent 60 minutes with a patient in a given month, you could actually bill 57 once and then the 99458 twice. So you'll see below I have a sample pro forma with just a physician group with 8 providers. And if each of those providers had 100 patients on the program, each you'll see that that's over $700,000 in annual reimbursement back to the organization. Just the remote patient monitoring program. So how do we get started? And it all starts with a prescription. To make it clear, this is doctor prescribed, just like you would prescribe a pharmaceutical drug, you're now prescribing a remote monitoring program. And there's 3 main buckets that you would typically prescribe RPM for. One for an acute patient scenario, it could be a heart failure patient post-discharge. It could be COVID symptom monitoring to look at things like pulse oximetry or temperature. The second is chronic condition management. For today's webinar, we're going obviously through remote hypertension monitoring, but others include type 2 diabetes, obesity management, and then the third is medication change. So let's say you're changing a patient from a beta blocker to an ARB for hypertension, and you want to see how well or not well that medication's working, whether you need to increase the dosage or lower it over time based on the outcomes. You'll now be able to do that proactively by having a patient enrolled in a remote monitoring program. I do want to make it clear that RPM is diagnosis driven, but it's agnostic to the condition. So there isn't one diagnosis that RPM is specific for, but it does require medical necessity. So if you were going to monitor a physiological data point in the clinic or on an ongoing basis, typically then it would make sense to monitor that patient through an RPM program and prescribe it based on that diagnosis. So what does a typical prescription look like? The way this typically works is that you actually create an order set through your electronic medical record, whether it's Athena Health, Epic, Cerner on the acute care side in the hospital setting, or you name it on the ambulatory side. And in that prescription, there's typically three components. One is the diagnosis for the patient. For today's example, we're going to use uncontrolled hypertension. You'll then have the requested studies, in this case, a 12-month protocol to monitor hypertension and weight due to prescription medication effectiveness. And then the third is the physiological data points that you're actually going to be monitoring for the program. And in this case, this provider put blood pressure and weight as the two data points that they'd want to monitor. And when you tie it all together, this is what it looks like with just 10 sample patients that were enrolled in the program. Hopefully we have some Game of Thrones fans on the line now, so we'll have all of our Game of Thrones patients here as sample patients. And you can see here that as we go through, if certain patients were enrolled in a given month, they'll be able to be eligible for that setup code 99453. Daenerys got 16 days of data as well in that month, so she was eligible for 99454. And then her care team spent 40 minutes, at least 40 minutes with her reviewing data or communicating with her. So you'll see she was eligible for 99457 and 58, which comes to around $175 in monthly reimbursement because she was eligible for all four codes. Aria, on the other hand, must have been enrolled in a previous month, so she wasn't eligible for 53 for the setup. And she only got 16 days of data. There was no communication or review for her in that given month. So her reimbursement was $62. And if you look at the very bottom, Ramsey spent, we actually was able to bill 58 3 times. So that's a total of 80 minutes of time spent with Ramsey. So 57 is the first 20 minutes, and then 3 units of 99458. So that's an additional 60 minutes of time spent. Which comes out to $240. So for just these 10 patients, the monthly reimbursement is a little over $1,000 for this RPM program in this practice example.
All right, here we have our major takeaways here. So for my part, monitoring the behavioral determinants of blood pressure, it is so crucial in reaching the more aggressive targets. Remember, what we've learned from the SPRINT study or the SPRINT trial is that an all hands on deck approach tends to work, tends to save more lives. And so addressing that aggressive target of 120 systolic, and while that is such a lofty goal, it does require some additional work on the lifestyle end as well, as much as we can do.
The second component here is that, especially in value-based arrangements that are working off quality metrics and MIPS and MACRA, combining lifestyle data, which is a key driver for improved outcomes and proven time and time again, as Craig mentioned, and combining that with physiological data like a blood pressure or a weight metric is so crucial to improving a quality metric, especially when it comes to uncontrolled hypertension. And then the third is that remote patient monitoring offers now a new billable program for your practice as the way to manage chronic conditions more effectively, like uncontrolled hypertension, but other examples like type 2 diabetes, heart failure patients, and obesity management as well. So with that, we're going to open up the floor to Q&A.
Yes, thanks, Samson. And thank you all for submitting questions. We did have a few come in on the line. So the first one we got is, What are your thoughts on the best practices for utilizing exercise and medication for managing uncontrolled hypertension?
Yeah, you can't really do this without emphasizing the exercise component. And of course, you may even have to modify someone's medication if they are doing, say, 3 bouts of exercise throughout the day, even if it's 3 10-minute walks spread across the day, each eliciting that post-exercise hypotensive effect. I mean, that could reduce somebody's systolic blood pressure by 7 to 10 millimeters of mercury and sustain that throughout the day. So, yeah, exercise, I don't know if it's underrated, but it is a powerful lifestyle treatment, mainly because it's a daily necessity, and without it, you know, we end up communicating it as a treatment mechanism. In reality, it's just a daily necessity. I hope that answers that question.
Thank you, Craig. Yeah, the next one that came in, which devices remotely measure hypertension, and does the patient have to have their own devices, or does the practice provide them?
Yeah, I'll take that one. That's a great question. Here at HealthSnap, we try to make it as simple as possible for physician groups, especially, to incorporate remote monitoring in their practices. And so a part of our program is that we actually provide a pre-configured cellular device to the patients that have been prescribed at no cost to the patient or the provider. And what that means is that when they do enroll in the program, when they get the blood pressure cuff, we would ship it directly to their home. They would take it out of the box, and it just works automatically. So they don't have to have a Wi-Fi network, for example, or a smartphone, or even use an application if they don't, if they're not comfortable using one. They can simply take their blood pressure reading right out of the box, and it would send to you as the ordering provider. As shown earlier on in the presentation, they will be able to download our application and see all their data if they would like to do so. But because we typically focus in a Medicare population, we found that having the as simple as possible is usually the most effective to at least start getting remote data to the ordering provider and care team that's managing that patient's care.
Great. The next one that came in, who in the practice can actually look at the data for time?
Yeah, I'll take that one as well. And that's also a really great question. So 99457 and 58, those are the 2 time element components of these billable codes. And CMS actually changed this in late 2019 to go into effect in January 1st, 2020, where these codes are now billed incident to the ordering provider and under general supervision, meaning that it can be a medical assistant, a nurse practitioner, a PA. Those are typically the staff members that are monitoring the data on behalf of the provider on an ongoing basis. And because it's billed under general supervision, they don't need to be in the same physical facility. They could actually be home right now monitoring the patient's health data that comes in every single day from the program, and that will be classified as time spent for those 2 codes, as long as the proper documentation supports it. As always, documentation is always crucial to the financial success of the program, and that's something that we work with all of our practices to ensure that documentation is done effectively.
Thanks, Samson. And the next one, actually, the next question we had come in refers back to that umbrella of telemedicine slide. It's, can you bill for RPM and telehealth together?
Yes, you can. And a lot of the practices that we work with around the country are doing just that. Telehealth is just the same as an office visit, more of an acute scenario, where as if we were on a Zoom webinar today and we're actually consulting, and RPM is more of the data and the context in between those telehealth visits. So telehealth is billed at place of service 2, RPM is billed at place of service 11 at the office level. They are separate and distinct code sets and very complementary to each other.
Great. So we did have one more come in, and we're coming up on time, but I wanted to answer one more. It's, what program/product costs are incurred by the physician group or health system?
Yeah, that's actually a really unique way that we partner with our groups, and it truly is a partnership. We actually don't, as a part of the program, offer any upfront costs. As I mentioned, the devices are included as a part of our program, and we work based on the success of the physician groups and health systems that we work with. So if the physician group or the health system is successful, both from a clinical outcome and or a financial reimbursement side, then we share in that partnership and that success with that physician group. If you'd like to learn more about our actual model and how we partner with our physician groups, you're more than welcome to schedule an online demonstration right on our website, as you can see there. And Sunny, if you'd like, you can drop the website link in the chat as well for all the attendees.
I'll do that right now. And we just wanted to thank everyone for joining us today. Thank you, Samson and Craig, for answering all the questions. I am going to share the link with everyone for HealthSnap's website. It's healthsnap.io. We hope you kind of walked away with a new perspective on how to manage hypertension remotely. Anyone whose questions didn't get answered today, a member of our team will be following up with you soon to answer any questions and to address any questions that might come up in the meantime during the day today. Please feel free to connect with our team on LinkedIn in the meantime, and stay tuned. We'll be announcing our September webinars shortly. If you're interested in learning more about HealthSnap's remote patient monitoring solution, please visit our website, again in the chat, www.healthsnap.io, and feel free to request a platform demo with one of our specialists. With that, we'll be following up with you shortly with today's recording, and please feel free to send us additional questions that may come up. We thank you again for joining us, and we look forward to talking more soon. Have a great day.
Bye, everybody.
Thank you, everyone.